Lipid profile also. How much? What the lipid?
Who is answering today?
Sir, Dr. Hussain, Dr. Mukani, Dr. Venkata, and Dr. Sachin.
Yes, sir.
Good evening, sir.
Yeah, good evening. Okay, just tell me again, who are people answering?
Sir, Dr.
Venkata?
Dr. Venkata.
Yes, sir. Here is Dr. Venkat.
Yeah.
Dr.
Then?
Mukani, sir.
And
Here,
Dr.
Dr. Hussain, sir.
Okay.
Here, Dr. Hussain, sir.
Yeah.
Dr. Sachin, sir.
Okay. Fine. I think we should start now.
Yes,
Dr.
sir. We
Gite
can
has
start.
joined.
Gite sir is there, sir. Pankaj sir is also joined. Good evening,
Well,
sir.
then
we should start. We should start. Sir.
Yeah. Okay.
Join, sir. Good evening, sir.
Good evening. Good
Good
evening.
evening, Gite sir, Pankaj sir, Gaurang
Good
sir. Good
evening.
evening.
Good evening.
Good evening, sir.
Okay. So Venkat, Mukani, Hussain, and Sachin, don't think that this is a case of VVF. Just take it as a long case, and from the history, then you come to some differential diagnosis and then the examination. Okay.
Okay, sir.
Fine.
Okay.
Yes.
Noted.
Okay. Start.
Those who are not presenting, please mute yourselves. Start, Vijesh.
So a 43-year-old female presented with the complaint of passing clear fluid per vaginum since 20 days and left flank pain since 10 days.
Okay. So let us start with Venkat. Venkat,
Yes,
you
sir.
tell us. There are two main complaints. Okay. So how we are going to ask the
Okay.
questions?
So 43 female complaints of clear fluid vagina for last 20 days. What is it? Continuous nature of leakage? Is it continuously drain or intermittent drainage? I want to know. And is it foul smelling or not? Is there any? Does there have any? Does there have any continence in between the normal continence mechanism is there or not? And nature, like quantity of fluid, is it a large volume fluid leak or small volume fluid leak? And is there any history of fever to associated infection? And I would like to know about the past surgical history. Was any surgery done in recent times? And if surgery was done, would like to know. Hello, am I audible, sir?
Yeah, go ahead. You're perfectly audible.
Yes, sir. And I would like to
Now
know.
he has given us history of fluid passing per vagina. So what are the different types of fluid that can pass through vagina? But most of the times we get patients coming saying that I'm passing urine through vagina, right?
Yes, sir.
But here he has given us history of fluid passing through vagina.
Maybe most common would be would like to know the past surgical history, sir. If there's any recent surgical history which was done in this patient So if it's something last 1 month or 2 months, or any recent surgical history done, of the patient has received any radiation in the past, or any patient has any delivered recently, in which case your urine will be the most, that will be the first differential diagnosis.
But the question was, what are the different types of fluid? Now you are going
Vaginal,
back to history of radiation and other things.
vaginal discharge, urine, vaginal discharge,
Can it not be ascites?
citus.
Can it be urine?
Ascites is less common, sir.
But it can be urine, it can be ascites, it can be whatever, right? Like you
Okay, sir.
said, some radiation and maybe some other malignancy or some hepatic malignancy, some ascites, and then has a vaginal surgery. Can be
Yes,
fluid, right?
yes,
But
sir.
because he has presented it like this, if at all he had said clear urine, I wouldn't have asked this question.
Okay, sure, sir.
However, now you started asking some questions, so you are asking suddenly radiation, suddenly
No, sir.
surgery.
Sorry.
So I would say just in your mind make a plan. You know how you want to evaluate the negative history,
Okay, sir.
right? So first you would like to find out whether it is what type of fluid. So if she says that there is urine, then what is it foul smelling like you asked?
Mm.
Okay, then whether
Okay.
it is low output or high output,
Okay.
whether it is continuous or it is
Continuous or
intermittent.
medium. And
So
whether
that gives
large
you some,
quantity or
yeah,
one small quantity.
how many
Number of
pads
times
is she changing,
getting. Yes, sir.
right? Then after that, you can ask the other negative history, whether there is any fever, there is any other discharge,
Yes,
any history of surgery done, any history of radiation, all those things you asked.
sure.
Any blood is coming.
Mm. Any history of hematuria also.
Yeah. Does she feel any foreign body?
Mm. Sure.
Right.
Would like to know since he has left flank pain also, there's any history of fever? Is it any getting or any vomiting associated with fever? It's getting infected or like to know, sir. And in this case, would like to know any past comorbidity, is it diabetic or any cardiac history is hypothyroid, and is there any most important any past surgical history in recent times, last 3 months or 1 year, any past obstetric history, any delivered recently?
Okay, fine. So Mokani, you want to add anything? Not the same
Yes, sir.
thing. Anything else
Yes,
you
sir.
want to add?
I would like to ask about the associated symptoms, also frequency, urgencies there or not. I would like to ask, and also I would like to ask whether the leak is there any relation to change in position or associated with any straining or sneezing, associated with any cough. I would like to add, sir. That history also I would like to ask, and associated symptoms. Yeah, I would like to ask fever, hematuria, and since there is a left flank pain, I would like to ask any associated signs of renal insufficiency is present, like pedal edema. That history also I would like to ask, sir. Along with that, constitutional symptoms like anorexia, malaise, weight loss, those history also I would add up in the end, sir.
So what are you
Okay.
guys thinking about the flank pain? Why there is flank pain?
It could be due to ureteric injury, sir, on that side, sir, left side.
Or
No.
ligation?
Ligation of the ureter, that the complete ligation of the ureter on that side,
Would
leading
like
to
to
the
know, would like to know the past surgical history, sir.
Okay, so we don't know any negative history. So at present, you know, don't. If the examiner asks you to why there is a left-sided flank plane, then why you want to talk about ureteric ligation? You understand? In this
Yeah,
case,
sir, got
after
it.
these two presentation, don't talk about. You can say it can be because of the ureteric obstruction, which can be because of the stone, it can be because of stricture or something else. And
Yes,
if
sir,
or
got it.
it can be if the patient is operated, then post-operative.
Yes,
Okay,
yes, sir.
fine. Okay, go ahead. Give the negative history. Brijesh.
Yeah. Patient was asymptomatic before 20 days. Later, she started developing clear liquid per vaginum. It was sudden onset, non-progressive, not aggravated on changing in position or on standing, continuous and clear, not also a foul smell. Soakage was up to 10 to 12 sanitary pads per day and with a decreased urine out.
Okay. Give all the history.
Yeah. So about the left flank pain, it was dull aching in nature, non-colic insidious. non-radiating, not as nausea, vomiting, or fever, and it was relieved on taking analgesics. So negative history. No history of lithuria, hematuria, fever, chills, or edema, or radiations, or past PV discharge, and no urine leak on cough previously. So there was one positive history is that she underwent abdominal hysterectomy for dysfunctional uterine bleeding 1 month back.
Okay. So, Hussein,
Yes, sir.
now looking at the history, okay, what is your differential diagnosis?
So, sir, as a previous history of vaginal means hysterectomy is there, so there would be possibility of vagico-vaginal fistula associated with ureterovaginal fistula. That would be my first differential diagnosis. Second diagnosis would be, sir, VVF along with some passed out stone or something else, and
whatever diagnosis you tell in exam, please remember that diagnosis you have to defend.
yes, sir.
Otherwise, the life will be difficult. So before telling anything to the examiner, think twice and tell. And it should be based on the positive finding with some negative history support. Okay. So अपने दिल को जो आया वो बोल देना नहीं है. Why you diagnose your first diagnosis is VVF with ureterovaginal fistula? Number one question. Number two, what are the findings? यूवीएफ एंड यूवीएफ दोनों है, ऐसा आपको क्यों लगा? हिस्ट्री में कुछ पॉजिटिव?
Yes, sir. So there is a prior history of hysterectomy.
So that doesn't mean did he or she should have यूवीएफ and vasovaginal fistula combined.
That is asking why you are thinking both VF and VVF.
So, sir, as it is associated with the flank pain, also the ureterovaginal fistula, I would keep in mind also, sir. That is the first point. But there may be some mixed pathology
So
of
is it possible to have flank pain without UVF in only VVF?
So if the vagico-vaginal fistula involving, sir, ureter, then it would be possible, sir.
So we
Large
don't know.
VVF.
Hey, Baba, some history, na? If patient says intermittently she is passing urine well, and
Yes, right.
or continuously leaking, something like that, sir is asking. Why
Typical
UVF and VVF?
typical history रहता है कि vaginal leak with intermittent normal voiding. अगर वो बहुत बड़ा फिस्टुला नहीं है तो, if it is very big size fistula, then everything will come through vagina.
So, sir, I would like to ask further question also, sir.
And whatever negative history you have to ask, you keep in mind कि for that you should know the causes of the vaginal fistula. And then one cause you have to rule out. So congenital का तो यहाँ कोई issue नहीं आता, तो everything is acquired only. So trauma है, surgery है. अब we don't know कि उसने सिर्फ leaking fluid पर vagina बोला है, inflammatory है, radiation है, malignancy है, वो सारी चीजें. तो तीन चार negative history पूछना है so that कि that particular point should get ruled out or should get finalized.
Right.
Spontaneous में tuberculosis है, obstetric history में recent delivery है. तो एक दो तीन क्वेश्चंस पॉइंट बोल के अगर बोल दिया तो एग्जामिनर को पता चल जाएगा he is ruling out the obstetric history, he is ruling malignancy, he is ruling out the radiation, he is ruling out the inflammation, tuberculosis, spontaneous हो सकता, trauma. तो एग्जामिनर को अगर इम्प्रेस करना है तो ये लिख के रखना है, ये केस आया तो मैं ये चीजें ऐसी ऐसी पूछने वाला हूँ और ये ऐसा ही बताने वाला हूँ.
Right.
Okay. So, Sachin,
Sir.
I want to ask you a question. That
Yes,
if
sir.
it is a vagico-vaginal fistula, what type of history you will get?
Sir, is it continuous leakage or in vagico-vaginal fistula, the leakage will be continuous, sir, as compared to the ureterovaginal fistula? And it will be, if fistula location also, it depends on fistula location also. If it is supratrigonal fistula, it may be, the leakage will be more on a dependent position, sir. If infratrigonal fistula of the patient when standing, the leakage will be more.
So you are contradicting yourself. I am asking you if it is, suppose if it is a vasacovaginal fistula. If, as you are saying, it is of supratrigonal, if it is much above the trigon and is a small fistula, what type of leakage you will get?
Intermittent.
Yes, sir. Yes, sir.
Yes.
Intermittent.
And if it is a very large fistula, what you will get?
Continuous. Continuously.
Okay, then maybe continuous.
And what will be the urination? If it is a very small, high fistula, simply passing urine in between or not?
In between normal
The
urine.
normal wording.
Normal voiding. And if it is very big fistula or a trigonal fistula near the trigon, what will be the situation?
No normal voiding, sir.
Normal voiding.
Then, so now this patient has got a continuous fistula. I mean continuous urination, and she is correct, in between she is
Yes.
passing. So what is your diagnosis? What is the most
Continuous-
probable thing?
Continuous fistula suggestive of large fistula, sir. Large vasacovaginal fistula.
No, but she is passing intermittently, na? For urethral also she is passing.
Okay, sir.
So what is the inference? What do you think?
Continuous. You might have a vesicovaginal fistula with fluid collection in the abdomen, which is causing flank pain, sir.
See, please don't
It's
complicate
a small
matters.
vesicovaginal fistula which is non-dependent and oblique tract that can have intermittent normal voiding.
How you have decided with history that a track is oblique?
No, sir. For intermittent vesicovaginal fistula with a normal intermittent voiding, I'm saying, sir.
So ये स्टेज में ना ऐसा कोई concrete बोलना ही नहीं.
Keep it
ये है
simple,
या
yeah.
वो है.
Keep it simple.
It can be just pulling up the urine inside the introitus. It can be just stress urinary incontinence. Patient को पता नहीं चल रहा है कहाँ से आ रहा है. हिस्ट्री है हिस्टेक्टोमी की मतलब अपने हमने पकड़ के लेबल कर दिया कि भैया उसको फिस्टुला हो गया. बस उसने हिस्टेक्टोमी कर दिया तो फिस्टुला हो गया. तो बहुत ही
Dr. Maheshwari was
सिंप्लीफाइड
asking
वे से
something.
इधर पूरा यूरोलॉजी मींस मैथमेटिक है. बहुत सिंपली सोचना है. बोलो सर. पंकज सर बोल रहे थे कुछ.
No, what you are saying is right. I was saying exactly that. That don't complicate matters. Don't speak more than what is necessary.
Exactly.
Like talking like Hussein, you spoke about stone disease, absolutely irrelevant.
Totally agree, sir.
How can you diagnose stone disease at this time? And Dr. Velan, don't talk of the details of fistula at this time.
Okay, sir.
At this time, we are only localizing where the disease is likely to be. So if the patient is passing urine and continuously leaking with left flank pain, the first diagnosis post hysterectomy should be ureterovaginal fistula. It could be a small vesicovaginal fistula which is near the ureteric orifice, or it could be, say, as sir said, leak could be very well be due to post hysterectomy stress urinary incontinence or vaginal pooling. So get through history very fast. Just say that I am suspecting fistula, I want to investigate further. And if you utter things like oblique fistula, supratrigonal, infratrigonal, associated stone disease, your viva will not move forward. You will stay here.
जो स्टेज में एग्जाम चल रही है ना, वो स्टेज से रिलेटेड ही बात करना. अगर अभी पर एब्डोमिनल एग्जामिनेशन नहीं हुआ, पीएसपी भी नहीं हुआ, कुछ भी नहीं हुआ है ना, कि हो गए, तो फिर कैसे पता चला कि हो गई? तो इतना पूछने के बाद सर ने जैसा परफेक्ट 4 डायग्नोसिस सर ने बोले उतना बोलना है. And then I want to examine the patient.
See, sir is not telling that patient cannot have a stone. May have incidentally finding, they can be, but it's not a common thing, right? You're talking about rare things. And when there is a clear-cut case of a fistula, you are talking about stone disease. Keep it simple, guys. You'll do well. Do what you are doing in your routine.
So again, let's revise things again. If suppose you are asked what is the differential diagnosis at this time, in very short, you first rephrase the history in few words. So this is a young lady post hysterectomy, left flank pain with leak with intermittent voiding. So my possibilities are ureterovaginal fistula, small VVF. I would want to investigate, or I would want to examine and then investigate. So give 2DD, give reasons for it, and move ahead. And that is exactly what we do in OPD. We don't analyze the type of fistula sitting in the OPD with history.
See, what Dr. Maheshwari is saying absolutely right. Okay. Every time there may not be 15 differential diagnoses. Sometimes you have to find out, there may be only one or two diagnoses. Sometimes it can be only one diagnosis. So you don't have to say, no, in exam, I have to give differential diagnosis means multiple 3 or 4 diagnoses. No, if it is not fitting, it is absolutely absurd. No, don't mention about that. And by chance, if you mention, you should know how to defend it.
And sir said, what you do in your OPD? I said, what you will do on your routine basis. When you see a patient, what you will ask? Sonography or whatever, go ahead. Rather than complicating it.
So, okay, let's go ahead. Now, what do you want to do? Huh? Sachin, now this is a history. And
Sir,
we know
I
now
will-
the probable diagnosis. Now, what do you want to do?
I would like to examine the patient, sir.
Very good. So, what are the
First,
important things you like to do?
first per abdomen examination, sir. Any scar of the previous surgery in
Okay.
supine position. After that, I would like to check at the
You
local
don't want to see
examination.
the general, or in this case, what about general examination?
Okay. General examination, nutritional status of the patient, sir.
Why nutrition status?
Because it is more common in the poor socio-economic status, sir. Vachai cohesion and fistula, if you are suspecting, it is more common.
Why?
Because
It is a surgeon.
ignorance of this
surgeon.
condition.
Sachin, the socioeconomic reason that you are talking about are obstetric fistulas. This is a post-hysterectomy fistula which has nothing to do with the class of the patient.
Exactly.
What you have read is right, beta, but you need to apply it properly. What sir is telling is for those obstetric fistulas.
Then one important thing we have missed till time is जो हिस्टेक्टोमी हो गई है उसके बारे में ज्यादा डिटेल हिस्ट्री में जाना चाहिए.
Exactly.
उसका क्यों हुआ हिस्टेक्टोमी, उसका स्पेसिमेन का हिस्टोपैथोलॉजी रिपोर्ट क्या था, इंट्राऑपरेटिव कुछ इवेंट हुआ है, ब्लड ट्रांसफ्यूजन देना पड़ा और किसी को कंसल्टेंट को बुलाना पड़ा, बहुत सारी चीजें. कैथेटर कितने दिन रखा, कितने दिन के बाद कैथेटर निकाला, लीक कब शुरू हो गया, डिस्टेंस बिटवीन हिस्टेक्टोमी कब
Whether
खत्म.
there was a hematuria post-operatively, whether there was a pain in suprapubic region, whether there was any discharge from the wound.
Whether it was very bad adhesions.
Yeah. So, Brijesh, do you have that history?
Sir, she underwent abdominal hysterectomy because of dysfunctional uterine bleeding. Because he has menorrhagia and pain. So, operative history was uneventful. There is no any transfusion of blood or no any complication as per the history given by the patient.
Was there any prolonged hospital stay? How long was the catheter placed?
That history was not there with the patient.
Yeah, so it was kept for basically, I think, 2 or 3 days because she doesn't remember also much. Otherwise, they always remember it was kept for a longer period of time. So what the history was given was that she had very smooth recovery for next 4 to 5 days, and in fact, she was discharged. And then she hardly had any other problem till the time she started developing this leakage per vagina and the pain. But as Dr. Venkat Gite said, it is very important, one, to find out that was there any problem during hysterectomy? Did it take a longer time to do the hysterectomy? Second thing is post-operatively, was there any bleeding, hematuria? Was there any severe pain in the abdomen? Was there any distension or any discharge from the wound or any other fever or any other complication secondary to that? So this is very important. Okay, so always ask. If you don't ask, it becomes a negative. Okay. So one is the nutritional status. Sachin, you are talking about nutritional status. Why it is important? Because now you want to improve the nutritional status so that when you do the next surgery, you don't come across the complication secondary to nutritional status. Okay?
Yes, sir.
Fine. Second thing is
Then
in
per
general
vaginal,
examination, what other important thing?
per vaginal examination, sir, I would like to see the
No, that is we are talking about general examination. What other important things?
Pedal edema.
pedal edema, any pallor is there or no?
Pain, is there any, like on tenderness, any fluid collection in the
That
abdomen?
is all local. All local. In general, you want to, I think you want to rule out whether there is patient is anemic. Nutritional status, anemia, and pulse rate, basically. Okay?
Yes.
Fine. Okay. Brijesh, go ahead.
She had a history of hypertension, was on antihypertensive medication since 5 years. Family history was complete obstetric gynecology history was normal previously. Had 2 children with normal vaginal delivery. The general examination was normal, sir. There was lower midline vertical abdominal scar for hysterectomy. No any sinus, no any skin changes over the scar, normal respiration, no swelling, no renal legal fullness. On palpation, there is mild left flank pain tenderness.
Hussein, in per vaginal examination, what you like to see?
Sir, by inspection, I would like to see whether there is any discharge is there or not, whether any skin excoriation is there or not, what is the labial fat plate, labial fat thickness is there or not. Then followed by, I would like to do the finger examination. Means whether the per vaginal any induration is felt or not. What is the distance from this external urethral meatus, and what is the surrounding margin, whether it is friable or not. Apart from that, any means palpable malignancy or something is there or not. Followed by, I would like to do the per speculum examination. I would like to look for similar things in a per speculum examination. Apart from that, surrounding means mucosal margin and whether it is healthy or not. I want to rule out through this per speculum examinations.
Mukani, you want to add anything?
Yes, sir. In the perspective, I would like to add, like to see any pooling of urine, any signs of inflammation is there. I would like to check that also, sir, along with that.
Okay. Okay. Brijesh, just show them.
There was no any local skin excoriation or no any inflammation, edema over the genitalias of the female. Normal female anatomy with evidence of clear fluid leaking, no cystocele or no rectocele, no any bleeding. Vaginal mucosa appeared to be healthy.
Per speculum findings.
Per speculum findings were also normal. We couldn't identify any discrete fistula on per speculum finding.
So Sachin, how often when you do per speculum examination in any post of fistula, how often you will be able to see the fistula? Is it very easily seen or it is very difficult to see?
If large fistula we can see, small fistula very difficult to identify.
If it is present at sir vaginal apex, then it won't be felt or it won't be seen by per speculum examination, sir.
So what are the reasons then you will not be able to actually see the fistula very clearly?
Edema and surrounding inflammations.
Yeah, and usually it is quite high and it is at the angle. Okay, it is not just carrying it to you. Because whenever they are doing the suturing, it goes into the anterior vaginal wall. And when you are putting a speculum, you are not able to see even the scar, the thing, suturing line, you may not be able to see very clearly. And plus, there you see, as you said very rightly, a small one, plus there is a lots of edema all around, becomes little difficult. Fine. Okay. Bridges, go ahead.
Sir, should I show the investigations?
No, let us, Mukani, what you want to do now?
First,
I would like to.
while doing the PSPV, don't tell in haphazard way. So whatever he start well, inspection may he talk about the labia majora excoriation. Then what can seen is leaking of the urine. Then size of the vagina, it is roomy or non-roomy. Then mucosa of the vagina is healthy or atrophic, inflamed, swollen. Then palpation. Palpation is any induration, hard thing palpated at any of the apex of the vagina. If it is large, then it can seen definitely. Then any suture material, anything prolapsing mucosa, if it is large. ये इतना ही चीजें मैं बताना है और अगर वो पूरा आउट से इन या इन से आउट बता दिया तो क्लियर रहता है और अपने बात में काफी क्लियर रहना चाहिए कि कंफ्यूज नहीं रहना चाहिए. So next.
I would like to evaluate the patient with a complete blood count, urea, creatinine, urine routine, sir. And also ultrasound abdomen and pelvis I would like to do, sir.
PSPV का फाइंडिंग अगर हो गया तो यहाँ डायग्नोसिस होना चाहिए, प्रोविजनल डायग्नोसिस. So whatever you have diagnosed on history and clinical examination, so the provisional diagnosis is diagnosis after the chief complaint and diagnosis after the examination is one and same or different?
Remains same, sir.
Remains same, sir.
Same.
So diagnosis is urotrovaginal fistula.
Sir, we can say like uretrovaginal along with small vesicovaginal if it is a high line.
नहीं तो अब फाइंडिंग क्या है, पर स्पेकुलम के फाइंडिंग बताए क्या उन्होंने कुछ? आप have you asked the findings?
So he told sir that is a similar finding without any abnormality found on the per speculum finding. So if there is induration which is not found,
So per speculum and PS there is no any positive finding. Correct?
right, sir.
So small fistula can be missed. So predominantly it is something is coming from not from the bladder.
Right, sir.
So uretrovaginal हो सकता है and plus minus small vesicovaginal fistula that can miss down the per speculum examination.
But sir, would you not agree that this cannot be kept as a diagnosis at this time?
Which,
you see, means associated small VVF cannot be kept as a diagnosis.
my first diagnosis at this place is uretrovaginal fistula alone.
So that is what I want to tell Hussain. I agree that in 25% patients there can be associated VVF, but
Right, sir.
let it be diagnosed on investigations. Clinically at this time we keep a diagnosis only of UVF.
Agreed.
Okay, so go to VVF only if the examiner asks, is it possible? Then say yes, that in 25% patients it can be associated, and I would keep a watch for that.
Right.
Traditionally, what test they used to ask?
Pre-swab test.
Pre-swab test.
So if we had reached there, somebody could describe that.
Patient is given tab pyridium 2 hours before it. Then patient is catheterized, given intravesical methylene blue. Three swab is placed. One is at the apex. Then in between, last one towards just at the outermost part of vagina. Methylene blue is instilled through the Foley catheter. Then we have to check for which swab is get soaked. If the outermost swab that is just at the below the gets soaked, two differential diagnoses. Either it can be a pericatheter leak or it can be a small ureterovaginal fistula. If the middle swab is soaked, it could be by methylene blue, could be a most likely vesicovaginal fistula. If the uppermost swab is soaked with orange color, it could be a cause of ureterovaginal fistula.
And if upper and middle both soaked, then it would be a combined uretero plus vesicovaginal.
जिद नहीं करते हुसैन.
नहीं then all three soaks, then pericatheter leak भी उसके साथ आ जाएंगे. अगर बड़ा ही देना है डायग्नोसिस तो फिर उसमें क्या है?
You see, Hussain, you are behaving as if you know the case and you know all the findings.
No.
Chale, let's move forward. Can somebody give the investigations?
Investigation, Brijesh.
So again, when suppose such investigations are projected in the exam, don't try to read every line. Say the examiner asks you to read the report, say that urine does not show hematopyuria, creatinine is normal, rest of the investigations are good. So just give points which are important to you at this time. Means in my last experience as an examiner, students tend to read every line. Don't do that. Okay. Do you have the sonography? So somebody could try reading this.
Venkat, can you read it? Okay, Sachin, you try.
So this ultrasound suggestion of both kidneys are normal, sir. There are no hydronephrosis, and the bladder is mildly distended. Left side is collection is there, sir.
Where do you see the collection?
Sir, hypoechoic, sir.
Which film? Which film?
Sir, lowermost, sir. The lowermost, second last.
Is it a collection or is it a fluid pooling in the vagina?
fluid, sir.
So again, my suggestion is don't overread the reports. Okay, and always start by saying what investigations this is. So I would say that this is a sonography of abdomen and pelvis. Liver appears normal, both kidneys look normal, there is no hydronephrosis, bladder is full, and some pooling of fluid is seen in the vagina. And stop there. Okay, and immediately ask for the next investigation so that examiner doesn't linger on this report. So what is the next you want?
CT.
Like to go over the CT urography.
Come again?
CT urography.
CT urography, sir.
With CT cystogram.
Hold on. Do you want a CT urography or a CT cystogram?
CT urography with CT cystogram.
CT urography with cystogram. Okay. Do you really want to say CT urography with CT cystogram? Means bladder images are part of CT urography. Why are you specifically saying CT urography with CT cystogram?
So the delayed image which may help for
You see, the moment you said CT urography with CT cystogram, you are hinting that you would want, say, a proper contrast to be instilled in bladder and cystogram images to be taken. I don't think we are looking at that at this time. You agree? You don't agree? Okay. Has a CT scan been done?
Yes, sir.
Yeah, Bridges, show the CT scan.
So the USG showed mild hydronephrosis ureter with abrupt cutoff of proximal to VUJ junction distal ureteric stricture on the left side. So now I will show the CT scan.
Mukani, will you like to describe?
I would like to see the images again, sir.
Bridges, just show him again.
Start talking what you're seeing.
The contrast CT of the abdomen axial section. Arterial fish showing the dilated pelvic alley system on the left side. Next image, please.
Where do you see the dilated pelvic axial system?
In the second image, the topmost one, you can see that H1 is there.
You call it at best.
The first row, the ureter is dilated in the
pelvis. Not
yeah,
really.
pelvis is sorry.
Yeah.
Pelvis and the ureter, upper ureter is dilated.
Mild fullness of the upper ureter. Okay.
And I'm tracing the ureter by both the ureters down. Next images.
Yeah, Hussein, can you describe anything or Brijesh, show them the result?
Hussein, what can you see? Please go
Maybe
ahead.
there is a collection on the left side, sir. Left column, there is a collection.
So there
On
is
the
a
left side, sir,
collection
second.
around the left lower
Yes.
ureter.
Yes, sir.
Go one image back. Okay, here we can very clearly see. If
Second
you
and
start
third.
seeing from the second image from the left, where the ureter should be, you are seeing the fluid collection there. And if you trace it in the line of the ureter, you can see that collection going retrovesical. Bladder is adequately full, and there is pooling of fluid in the vagina. Go to the next image. Again, here we can see mild fullness of the left renal pelvis with pooling of fluid in the vagina and fluid around the left lower ureter with mild hydronephrosis till the bladder.
That's it.
So, okay, what's your diagnosis now? What do you want to do next?
My diagnosis currently is ureterovaginal fistula, sir. So I would like to.
Now you can also say where exactly is the injury. Just
Injury
say
in the distal ureter, distal 1/3 of distal ureter.
Yes.
Left
So
distal ureter.
right. And so what next? What do you want to do?
So I would like to go ahead and I would like to do a cystoscopy. Before that, I would like to explain the patient. So what is my diagnosis and everything? I would like to discuss with the patient and then I'll explain that you have to do cystoscopy also. Then
What's your plan? Why do you want to do cystoscopy? What are you trying to look at in cystoscopy? What do you want to see in the bladder?
the bladder, any associated vesicovaginal fistula is there, I will see, sir. Any other abnormality is there.
Apart from that, sir, we can think about this bladder capacity also. We may require reimplantation in a later date. We may do cystoscopy RGP, though the stenting may be difficult as patient presentation is late. So we may think of this initial urinary diversion. In a later date, we may think of this fistula management. So we may do this PCN for this time.
Don't you see sometimes slough in the bladder, stitch in the bladder? These are the things also you see, na? Sometimes gynec surgery is done. Have you ever seen stitch inside the bladder?
Okay. So I want to, Hussein, you are answering, correct?
Yes, sir.
So Hussein, I want to say, as there are two things. You are saying that you want to do a cystoscopy.
Yes.
And with a cystoscopy, you want to do diagnostic cystoscopy or a therapeutic cystoscopy?
Sir, I want to do diagnostic as well as therapeutic, sir.
Okay. So in diagnosis now, when you do cystoscopy, what are the things you want to see? Start from urethra right up to the bladder. Tell me.
So starting from this urethra, sir, to look for any distal obstruction for bladder, whether any associated fistula is there or not. what is the bladder capacity and bladder wall thickness is there. Apart from that, I want to do this RGP also.
No. Why you are one minute. Let us go systematically. Why you are saying that you want to see whether there is any associated fistula is there or not?
Sir,
Didn't get you, sir.
conventionally, the such cases are investigated by IVP and widening cystogram or stress cystogram. Okay, so that is now replaced with CT urography and delayed CT cystography. The word should always be there, delayed CT cystography, because if you done a cystogram, CT cystogram in early phase, bladder may not be filled, contrast may not be reached up to the bladder, and the fistula may be missed. So along with this CT urography, delayed cystography should be done as a primary investigation in each and every case where you are thinking there may be some VVF. थोड़ा भी चांस अगर आपको लग रहा है तो वो करना ही है. Conventionally, everywhere all people will do it. Otherwise, you have to go for then cystoscopy. So before going invasive investigation, you have already doing a CT scan, and with that CT scan, you can do a CT cystography. So this is one investigation. So you can rule out both the things. This is one thing. Here, for cystoscopy, you have to do a cystoscopy or not to do a cystoscopy at this juncture. So what is plan in your mind? So if you want to intervene, then you have to confirm it. Okay? There should not be any associated vasovaginal fistula, then size of the bladder, and if it is a flap is required, whatever you are telling that may be true. But here there is a collection around the lower ureter, as well as you have to take into consideration the clinical picture, local examination, tenderness, fever, liver. For treatment right now, or you want to divert. Then duration from the hysterectomy, अभी कब presentation का क्या duration है, clinical picture क्या है, वो अगर सब कुछ negative लग रहा है, everything looks good, and there is no collection, there is no infection in that collection, then cystoscopy rule out the vasovaginal fistula, and in same setting go for the treatment. Correct. If you are thinking there is local tenderness is there, fever is there, leukocytosis is there, a lot of collection is there at the lower end of the ureter. So the contrast is coming slightly reaching up to the bladder on that side or not, or completely extravasity. If stream of contrast is coming to the bladder, and if it is early post-operative period, not after 2 months or 3 months, when the fistula is epithelialized, then one can go for the first management for the any ureterovaginal fistula in early part of the early post-operative period is degestenting or diverging in non-complicated patients. If you think it is a complicated, if it is complicated, locally you are thinking there is infection, collection, then you have to go for a patient. So everything has its own role at one place. So कुछ भी investigation अगर बोल रहे हो, cystoscopy बोल रहे हो, तो then as examiner I am thinking you are planning for some treatment right now.
So in this patient, when there is no fever, no features of sepsis on the basic pathology examination, our plan will be to do a cystoscopy, rule out any associated fistula in the bladder, do a retrograde pyelogram, and place a stent. Okay, I don't think, Hussain, you should be talking of PCN at this time in this patient.
Sir, but if sorry, but if there is any complete transaction, sir, and if we are not able to negotiate this glide wire above this injury site, then we may think of the urinary diversion by route of PCN, sir.
Yes, so maybe, but more often You see, in the last image, you can see the ureter down till the bladder. So in this particular patient, are we really suspecting complete transaction? Answer is no. Okay. So our plan predominantly, because the collection is not very significant. In complete transaction, you are likely to see a much higher collection. In complete transaction, you will not see hydrouretronephrosis because the system drains very freely. So the very fact that there is mild fullness of the kidney and ureter, probably it's a narrowing associated with leak. So it is not a complete transaction. So this patient, you should give one attempt at degestenting.
So, Hussein, how you can reply to this explanation by sir? I am totally agree with you, sir. My primary plan is degestant only. If at all I fail to do it, then I will keep in mind that patient may require. So I will be ready for the patient also. But primary digestant, and I will accept that. ऐसा accept करके आगे निकलना है. गलती से बोल भी दिया पेशेंट तो उसको कैसा भी करके आगे वही रुकना नहीं.
Okay. So Venkat, I am asking you, Mukani, Hussain, Sachin, all of you. Now let us go to the management. Okay. So I am asking you a question. Number one, you will like to do only a cystoscopy to find out whether there is any associated fistula or bladder is absolutely clear, and you want to establish that it is a uretrovaginal fistula. Number one. Number two, you want to do cystoscopy and you want to do even RGP to see at what level there is a transaction of the ureter. So that is again the second diagnosis. Third, you want to do cystoscopy, you will like to do RGP, you want to put a guide wire and you want to negotiate that fistula and you want to put a digestant. If you can't do it, you will like to do ureteroscopy and try to see that if you are able to negotiate the guide wire into the upper tract and you want to put a digestant. And fourth, whether you want, if you can't do this digestanting on the spot, you will decide to do the surgery and you will do the reconstructive surgery. So Venkat, out of all these things, what you want to do? Hello. Have you understood, Venkat? Okay. Mukani, what you want to do?
So I would like to do a cystoscopy, do RGP, sir. Like I said, I would like to try to place the stent initially, sir. So if the stent is negotiable and able to pass, I will place the stent. If unable to place the stent, then I will go ahead think about placing a nephrostomy, sir.
Okay. So, okay, there is one thing. So why you want to put a nephrostomy?
To divert the urine, sir, so that
why you want to divert the urine?
Small collection. There is a small
why
collection.
You want to divert the urine?
There is a small collection near the pelvis lesser, so it leads to fibrosis and inflammation. So to reduce that and divert the urine, so that when we go back, the inflammation and fibrosis will be minimal in that area, sir, while during surgery.
You don't want to, suppose already 1 month is passed.
Why
without putting a nephrostomy, you cannot do a primary surgery?
Exactly. Why sir is asking this question? You think over it. Because examiner is tending towards the primary surgery.
Okay, sir.
Correct. तो
yes, sir.
अगर उसको डिफेंड करना है तो I am not planning a primary surgery because 1, 2, 3, 4 जो भी तुमको जो रीजन है तो that minimal collection along the bladder, along the ureter, then अगर कुछ ल्यूकोसाइटोसिस है तो वो बताना है, अगर कुछ फीवर है तो वो बताना है, नहीं है तो प्राइमरी सर्जरी मिनिमम कलेक्शन अगर है और इन्फेक्टेड नहीं है तो कर सकते हैं, उसमें कोई ये नहीं है, वो तो रॉन्ग नहीं है प्राइमरी सर्जरी भी करना. लेकिन अगर पेशेंट बोल के फंसे गए हो तो बोल देना है कि भाई कलेक्शन था, सो आई वांट टू वेट फॉर सम टाइम, आई वांट टू रिजॉल्व द पेरीयूरेट्रिक इन्फ्लेमेशन एडिमा and to resolve the collection, and I will go for treatment for uretrovaginal fistula in delayed way. So no one will blame.
Sure.
So Mukani, you can say that If you want to justify, you can say, okay, sir, I like to do a PCN because it will, decrease the whatever edema and inflammation and the collection and the surgery will be better. And there are chances that I may get a bigger length of the ureter. Number one. Number two, till the time I'm planning for the definite surgery, patient will be dry.
Okay.
Okay, so these are the two advantages which are having. So I will like to do the PCN.
Okay.
Or you can say, okay, sir, there is hardly any drainage, there is no infection, no inflammation. Already 4 weeks have passed. Okay, so in this case, I may go for a primary reconstructive surgery.
Okay.
Okay, so Hussein, what you will like to do? Again, I am putting you. You want to do cystoscopy only? You want to do cystoscopy RGP? You want to do the guide wire, the ureteroscopy, digest stenting, PCN, or you want to do definite surgery?
Sir, as the patient having a late presentation, sir, I would like to do cystoscopy with RGP followed by digest stenting, sir.
And if it doesn't happen, then?
So, sir, if intra-op call would be there, and then means if there's a golden, means if it is in a period of golden period, means within a 72 hours, then I would like to think of definitive repair, sir. But there is a late presentation, so I would like to put a stent and at least wait for 3 months, and then I will do the further management, sir.
You want to wait for 3 months?
6 weeks, sir.
You want, huh?
6 weeks, sir, for healing, adequate healing time.
So now tell me, what is the difference between vaginal fistula and ureterovaginal fistula? Suppose if you are called during the surgery and they say that probably we have transected or damaged the ureter, what you will do?
Immediate repair, sir.
So in that, will you do immediately PCN and wait for 6 weeks?
No, sir, immediate repair.
Immediate
Suppose you are
repair.
called 24 hours after the surgery.
Still up to 72 hours, within 72 hours, if we detect it early, we'll repair as early as possible, primary repair, sir. Early repair is preferred, sir.
So Dr. Venkat Gite has also explained you why you want to do PCN. Correct?
Yes, sir. The
So in
patient
this
is
case,
unfit. Yes, okay.
so in this case, you want to do PCN or you don't want to do PCN? Suppose the patient, now another question. Suppose the patient comes after 6 weeks. Patient has come to me. I have not done anything. I told patient just wait for 6 weeks. I have not done PCN. Okay, I have not done PCN. You will do PCN or you will directly operate?
First, before that, I will
yes or
assess
no?
the patient whether
No, patient,
is in,
this patient, no, this is a situation, hardly any collection. Patient has got continuous leak. Okay, so because he has got a continuous leak means everything is draining.
yes.
Patient doesn't have fever, patient doesn't have pain, there is no other problem. And already 4 weeks की जगह पे मैंने उसको बोला कि नहीं, don't do anything, you just wait for 6 weeks and come back to me for a primary, definitive surgery. Now he has
Yes,
not come to, she has not come to me, she comes to you. So Mukani, what you will do? You will put a PCN or you will operate?
I will operate if the collection is very minimal, renal function is good, patient is not in sepsis. I will try to do the primary repair when she presents to me, sir.
Hussein, what you will do?
Sir, I would like to do cystoscopy, RGP, and
No, everything is done. No, it is, you are not able to do anything. I have tried everything. I have not done. I mean, I cannot get digest stenting done. So I told patient that wait for 2 weeks and I will do the definitive surgery. Now he has come. She has come to you now. You will do PCN or you will do definitive surgery.
Sir, how much it time from the surgery? How much time duration,
6
sir?
weeks.
6 weeks. So, sir, I will do this ultrasonography and whether there is a residual hydronephrosis is increasing or not. If it is not increasing, patient is stable, no signs of any septicemia, then I would like to wait for further at least uh, 3 to 4 weeks more. Followed by first I will do the cystoscopy, then do RGP and define whether there is a ureteric fistula or stricture. Then followed by I would like to plan further management.
Okay, so Sen, now let's make things clear here. So what sir is saying is that you do a cystoscopy retrograde pyelogram, you are able to put a stent, your job is done as of now. But if you are not able to put a stent, then what is the logic of waiting for 3 weeks or 1 more month?
To increase the collection.
And increase the stricture, increase the heteronephrosis. Why are you waiting?
देखो टाइमिंग पीरियड फॉर वसक vaginal fistula or timing for uretrovaginal fistula. So you usually wait in the vasa vaginal fistula for to resolve the
Understand the difference in
inflammation,
the
edema, necrotic.
pathophysiology of both the diseases. In VVF, kidney is not at risk, and you need to do the repair at the site of injury. In UVF, kidney is at risk, and you are doing a repair of a normal upper ureter to a normal bladder. You are doing no repair at the site of injury. So whether there is some inflammation or not is not going to make any difference in your success. In VVF, you are operating at the site of injury, which is inflamed. And I have no risk of kidney even if I wait longer. So waiting for inflammation to subside is a good idea in VVF. But in UVF, why do you need to wait? You will be taking the normal good ureter and fixing it or attaching it or doing a reimplant to a bladder which is not injured. So there is no question of operating in inflamed area.
So uncomplicated uretrovaginal fistula, whenever you see the fistula, treat as early as possible by surgical way. That's all.
Absolutely. So there is no logic of waiting in UVF.
Application of all your knowledge as per the situation.
So they, Dr. Venkat and Dr. Gite Maheshwari has beautifully explained you. They have given you the perfect result. And only one more thing I want to add in vaginal fistula is because it is dependent, condition. So the chances of failure are high. And that is why you want vascularization to take place. Not only that, infection, inflammation, everything to subside so that your fistula success rate, repair success rate is maximum. Understood? So he has explained you very nicely. Both upper ureter or middle ureter, which is normal, you are going to feature it to the bladder, which is normal, or you are going to take flap or whatever it is. Okay? So there is no need to wait. That is why we want to step. There is a difference between, you won't believe, but couple of times I have been called, they are so much in panic, the gynecologist, and they said that no, we have to face the patient. Why you want to do PCN and wait for 6 weeks? Please do the primary repair. And you won't believe, there are a couple of times when I have done on 5th day, 6th day, I have done uretrovesical anastomosis and a Bovary flap. And nothing has happened. Understood? Sachin, Hussein, is it
Yes,
clear
sir.
to all of you?
Yes, sir.
So
Yes, sir.
ureterovaginal fistula treatment is surgery whenever you see the or diagnose the fistula, provided that
Pro-
it is not complicated.
Yes, provided there is no big collection and infection, another complication. Okay, very good. And always, as you have, all of you have said very rightly, first you must try to put a digestion. There are very good chances nowadays that you will be able to put the digestion in more than 50 to 60% of cases. So now let us see what we did. The Bridget.
So we did, sir. I will show the CT report first. It showed dilatation of renal pelvis with ureter and narrowing of the terminal ureter before UV junction. Diffuse urothelial thickening and enhancement and inflammatory changes. Encasement of terminal ureter adjacent soft tissue in the operative bed. And mild perinephric fat standing in xerotasphyxia. And there was a leaner, thin streak of contrast communicating in urinary bladder anteriorly in the vaginal wall. So we did a VVF repair and left degestenting.
So both were affected.
Yeah.
Okay.
Do you have the cystoscopy image?
No, sir.
Okay.
Okay. So now, Venkat. Venkat is there? No. Okay. Mukani, I want to ask you one question. That suppose there is only ureterovaginal fistula, or in this case also you put the digestion. How many days you will keep it?
After the surgery, sir. After the implant, you was asking, sir.
No, we are not in implantation. We only put the digestion.
I don't know, sir.
Okay, Hussein.
4 to
When you
6
remove
weeks,
the
sir.
digestion? Huh?
4 to 6 weeks, sir.
4 to 6 weeks. Okay.
Yes.
Sachin?
6 weeks, sir.
6 weeks. Another question. Before removal digestion, will you like to do any investigation?
Do RGP at the time of digestion removal.
Yes, sir.
So you will do RGP at the time of
Digestion removal.
digestion removal. Okay. Okay, fine. So second case, can we go to the second case?
Sir, one doubt in this case.
Yeah.
If it's a case of ureterovaginal fistula, and if you're planning for definitive surgery like ureter reimplantation, Vogai flap, at this point, would we like to know what is the biopsy report of this uterus, sir? What there's any malignancy or if there's any
So
based on
that we already asked, na? And we see Dr. Gite told you, na, that he will
Okay.
ask about the biopsy and everything. And
okay.
and we are
And
yeah,
if
it's a
biopsy-
presume. It is a
in-
benign. Because there was a
Okay.
fibroid. Basically, she was operated for the big fibroid. So
Okay,
we know
sure.
the
Sir.
history.
Okay, sir.
Okay. So then ultrasonography, it was shown. There is
Okay,
another ultrasonography which is before the surgery. So that is showing a
Okay.
big fibroid. Okay.
Okay. So one more doubt, sir. The same biopsy was something like malignancy or sarcoma, which needed chemotherapy or radiotherapy. What would be the treatment care of that point, sir? The same patient has cancer malignancy, which needed chemotherapy, radiotherapy. So would you do definitive surgery and then go with chemotherapy, radiotherapy, or would just do a PCN, divert the urine, get the chemotherapy RT done, and do a definitive at a later date, sir? Doubt.
No, first go for a definitive surgery, because once
Okay.
you give chemotherapy or radiotherapy, the surgery will be very difficult.
Okay, sir. Sure. Sir.
Mainly after radiation therapy.
Sure. Thank you, sir.
And if you give the chemotherapy, it may be delayed for many months.
Okay, sir.
So
Thank you.
as such, you can within 3 to 4 weeks, you can do 3 weeks, you can do the ureterovaginal or even very early, you can do uretrovesical anastomosis. Keep the DJ stent, and once the DJ stent is inside, okay, and after you feel that healing has taken place, you can go ahead.
Okay, sir. Thank you.
Sir, I have one doubt, sir. In a book,
Yeah.
they have mentioned if small fistula not visible on examination, we should go for MCUG, sir. So, at what stage can we go, sir? Or, like in this case, sir, small vesicovaginal fistula.
Yeah, you can. That VCUG you can do anytime.
So
Patient has
if you
already
have a
developed a
clinical
fistula.
suspicion of VVF, which you cannot see on clinical examination or on CT urogram, then a VCUG can be done to see. And sir had used a very perfect term which is called as a stress VCUG or stress cystogram. Can you tell me what is stress cystogram?
Compress in the bladder, or like in like
Voiding film we usually see.
So stress cystogram means you need to fill the bladder enough till the patient has a voiding sensation. And when the patient is straining for urine, that is the time you will see a small fistula. So the bladder should be filled enough for the patient to have a good sensation. And the sequence of this cystogram would be a plane image, a cystogram image, a stress cystogram image, which should be both AP and obliques, and then drain the bladder and post drainage images.
Good. Any other questions, or we go ahead with the second case?
No questions.
Okay, Bridget.
The 50-year-old female present with a complaint of passing urine per vagina since 15 days.
Okay. So, Venkat, now you are here. Just
Yes, sir.
fatafat, what are the important history we'll ask? Now you know everything.
Was it continuous, intermittent? Is it
Yes.
foul smelling or not? Does it change in position? What is a like large amount of fish or small quantity? How much pad she changes?
Okay.
And is
Then,
she continent or not continent?
okay, whether she's passing urine per
Yes,
urethra or not.
You see,
and
instead
Then
of
whether
saying
there is
continuous or
there is blood.
intermittent, the most important history will be, is the
continent.
patient passing urine normally other than leak, or is she only leaking?
Okay,
That's
sir.
the first thing you should talk about.
Okay, sir.
So
Okay.
scientifically it is intermittent normal voiding.
Yes.
Okay.
Are there any exceptions to that? There is a fistula only on one side, but patient is not passing intermittently any urine.
So what Dr. Hiren is asking you, if the patient has got continuous leakage
Yes, sir.
and patient is not passing urine per urethra, what are the differential diagnosis? In the fistula, I am asking very clearly, in the fistula, what are the differential diagnosis?
Vesicovaginal fistula.
Large
So
vesicle.
large vaginal fistula, right?
Yes, sir.
Second, I'm giving you hint, there is no vaginal fistula. Mukani,
Sir,
I'm giving you a hint.
Hussein,
Sorry, sir.
Solitary.
so Sachin, can it be both the ureter which are cut?
Solitary kidney with uretrovaginal.
uretrovaginal. There is no uretrovaginal fistula, okay, but there is no vesicovaginal fistula. So second possibility is that both the ureter are cut. So it is a bilateral uretrovaginal fistula. Third will be one is ligated totally, so it is not pouring any urine, and second side there is a uretrovaginal fistula. And the last and the most important what Dr. Hiren Sodha is saying is there is a solitary kidney with uretrovaginal fistula. So these are the conditions where there will be a continuous leakage and peruretal normal voiding will not be there. Okay.
Yes,
Keep all these combinations in mind, okay?
Okay. Fine. We just go ahead.
Negative history was insignificant. So she had a large uterine fibroid for which she underwent hysterectomy. After 15 days of that, she develops these symptoms. Patient was catheterized with 14 French Police at local nursing home. After 7 days of that, patient still had passing of urine per vagina. So she was referred to us.
Yeah. So now what do you want to do?
After hysterectomy, when catheter was removed?
Yeah, it was removed out of 72 hours. So now what do you want to do?
Would like to ask the intraoperative event. How was it? Whether was there any injury to the ureter intraoperatively? If it was there any complication in the major surgery, prolonged hospitalization, was the catheter?
Yeah.
What was the duration
Okay,
of surgery? What is the histopathological finding of this specimen?
Yeah. So I'll tell you that this patient had undergone, it was very clean surgery as usual. The gynecologist said that they could not see the ureter or anything in the vicinity. They had taken utmost care. They were very near to the uterus and they were very near to the vagina. The bladder was beautifully separated away, okay, from the uterus, and there was no injury to it. Even the post-operatively, there was no blood in the urine, no hematuria. Patient did not have any urinary complaints after removal of the catheter. There was no suprapubic pain. There was no collection. There was no discharge from the wound. And the histopathology was that there is a big fibroid and no other complication.
So if you just want to complete the perioperative history, you should ask for post-op fever, pain, and ileus.
Yes, these are the three important things: fever, pain, and ileus, and the distension of abdomen.
Yes.
Okay, so these are the four important things. But it was absolutely post-operatively, she was absolutely fine. They had started also, orally within 24 hours. Yeah. So, Venkat, what do you want to do now?
Now, again, you see, she had a catheter for 7 days. So
Yes,
I would
sir.
also want to know how was the leak when the catheter was there in place?
Patient still passed urine per vaginums. Even catheter was there.
Okay, so they have told us this. Okay, fair.
So based on history till this moment, looks like patient this might have a delayed presentation. So maybe distal ureteric injury with the ureterovaginal fistula. He was already on catheterized. Leak has not subsided even after catheterization. So at this point of time, a working diagnosis would be a ureterovaginal fistula. So it needs further evaluation with the imaging to confirm it.
Is there any associated flank pain, sir?
No.
Okay.
So, Dr. Venkat, instead of saying ureterovaginal fistula, you can also have similar thing in a large VVF.
Okay, sir.
So a large VVF may still continue to leak with the Foley catheter in place.
Okay,
So
sir.
UVF keep a diagnosis only when you get a classical presentation
Pain
of
abdomen.
flank pain is one, but classical presentation of spontaneous voiding with leakage.
Okay, sir.
So with this history, I would say that this is probably a large VVF.
Okay, sir.
Okay, so what next?
General examination.
It was normal.
Systemic examination per abdomen, any scar, visible scar, surgical site infection, visible urine leak is there or not, abdominal distension, flank pain,
No flank pain.
Okay.
tenderness, sorry.
No, any one of you can just describe how you are going to do per vaginal examination. Dr. Gite has very beautifully told you. So just tell. Sachin, will you tell us?
Yes, sir. First, I would like to see for labia majora, any irritation or any urine collection is there, or smell of the discharge. Then vaginal mucosa, healthy or any atrophied. Vagina is roomy or small size. Then after palpation, I would like to look for any induration is there or no, and any foreign body is there or no.
Future material is seen or not.
Material, sir. Yes.
Then any fluff, correct?
Or
And whether you can see any fistula.
fistula present on anterior wall.
Okay. Fine. So, Bridges, any finding? Positive finding?
No, sir. No, sir.
Okay. Fine. So, Hussein, now what you want to do?
What about per speculum finding?
Yeah, per speculum they said.
For speculum, there also no, we couldn't see any vaginal fistula or
Any
abnormality in the vaginal mucosa.
any induration was felt or not?
No, no.
Mild
No.
induration, nothing more, which is usually seen.
Okay, sir. So I would like to investigate this patient with complete blood count, renal function test, urine routine, along with ultrasonography, abdomen plus pelvis, sir.
So, Bridges. Yeah, so 15 to 20%.
Are the epithelial cells.
Epithelial. Epithelial cells are
Epithelial cells.
15%.
Because it is per vaginal, no? So it is contaminated, correct?
Yes.
Fine. Bridges, show other things.
Ultrasonography.
So, patient was directly referred to us with a CT report. Unfortunately, we didn't have the sonography. Post-operative.
Yeah, sure. Show all the film. And then
So the report, sir.
okay, who wants to? Any one of you want to comment? Sachin, Hussein, you want to comment on this CT?
This is plain film, sir, in transverse section. I'd like to see, sir, contrast delayed film, sir.
Doctor,
So the contrast.
no, patient have only came us with these two only films.
Next film, sir.
So the next one. Hmm. See, there is a contrast. Can you see the contrast? Can you see on the left side?
Kidney is
Pelvis,
smaller.
little smaller comparatively, but can you see the
Uptake is
contrast
also
and
less.
dilated pelvis and ureter?
Dilated pelvis and
Yes.
ureter.
Yeah.
Even
Okay. It is not. It is little suboptimal. Okay. Okay. Bridges. Tell them.
So loss of integrity and continuation of distal left ureter, 2 centimeter cranial to UV junction with extravasation of the contrast, resulting small hypodense collection in surrounding fat stranding measuring 1.5 cross 2 cross 2.1 in dimension respectively, abutting the superior end of the left lateral wall of the vagina. A thin communication seen in between left lower ureter and left anterolateral aspect of the superior end of the wall of the vagina measuring 3 mm in width, resulted contrast filling in the vagina.
So now, Sachin, have you understood? The first case we were discussing that why there is a left-sided pain with
Yes, sir.
so we were saying one of the thing can
Yeah.
be either it is a ureterovaginal fistula or it can be a vaginal fistula very near to the ureteric orifice, right?
Yes. Yes.
So the first case you saw that way, right? In this case, there is no pain in the left leg,
Got it.
and still, and that is why when you put a catheter, the leakage has not stopped, and it is ureterovaginal fistula. And why there is no pain?
No obvious collection or
No option.
no imprint. Maybe
No
mild
obvious.
continuity of the urine still going into the bladder, not complete disruption.
That is one thing, but most probably because there may be a nick, okay, and there is not sudden hydronephrosis hydroureter, and there is not severe or moderate
Great.
hydronephrosis hydroureter. That is why patient is not getting pain.
Okay.
There is even no perinephric significant fat stranding, sir.
Yeah, and there is no infection, no pyelonephritis.
Right.
Correct. So now what you want to do?
Since we'll try for
Sachin, Venkat, Mukani, and Hussain.
Yes, sir.
Again, the 5 things last time what I said is you want to do cystoscopy. Along with that cystoscopy, you want to see the left-sided RGP. You want to put a guide wire. You want to do ureteroendoscopy and put the guide wire and do the digest stenting. If you don't do the digest stenting, you want to do PCN or you want to do direct stenting. Chalo, step by step. So Mukani, you start. What you want to do?
I would like to do first a cystoscopy, check the bladder, look for any other associated, any small fistula, is there a vesical fistula, any small, anything missed, and the same sitting, and I will go ahead and do the primary repair of the ureter on this.
Okay. So Mukani, what you want to do? I mean, Venkat, what you want to do?
this patient with a small 3 mm fistula. So I'll just try cystoscopy. If we able to do RGP, possible for a stent in, sir. If guideway is able to reach the PCS and stent is able to good, I'll put a stent in, wait for some time.
So Hussain and Sachin, I want to ask you, will you like to do RGP? Or you will like to put a guide wire and you put the ureteroendoscopy and negotiate the opening? Or you want to do RGP?
RGP.
Want to do RGP.
RGP.
Why you want to do RGP?
So
So,
put the passage of guide wire, it doesn't go into the false tract.
Why you want to do RGP? What will happen if you inject dye from below? Where it will go?
It is going to the kidney or not? You have to see. Tract is intact or not.
But what are the chances? Where it will go?
Into peritoneum.
peritoneum.
That means you are increasing and you are putting the dye inside. There are chances that you may cause an infection, or suppose there is a small check which is holding the ureter. No, another question. You want to put a guide wire directly from the ureteric orifice, or you would like to put the URS scope inside a small 4.5 French URS and go and see?
Small 4.5 ureteroscope would be better, sir.
So again, three questions. Whether you want to first inject, do the RGP. Second thing, you don't want to do RGP, but you want to put a guide wire, or you directly want to put the ureteroscope. These are the three options. Sachin, what you Sachin, what you want to do?
Under vision, sir. Under uretero
Under vision. Hussain, what do you like to do?
Same, sir. Under vision ureteroscopic placement of guide
Mukani?
wires.
Under vision only, sir.
Okay. So let us ask Dr. Venkat Gite and Maheshwari, sir.
So, sir, I would feel that the answer should be that I would always do a retrograde pyelogram. It will give me a roadmap of what problem is there. Using the word roadmap becomes very important. And then obviously you will not be pushing the contrast inside the ureter. It will be
Low
a
pressure.
gradual, slow under
Slow.
fluoroscopic control installation of contrast. If
Fast.
luckily the contrast goes up, then the next step would be to put a glide wire. If nothing works, then probably you may consider putting in a ureteroscope. One option here could be what is called as rendezvous procedure, where you could put a wire from above and get it out from the using the ureteroscope. But let's not go there. The sequence should be a RGP attempting a guide wire, then maybe a ureteroscopy, but definitely not. I would definitely not start with ureteroscopy.
I totally
So-
agree with Pankaj sir that one attempt of guide wire should always be made before you go directly with ureteroscope. RGP
Yes.
and guide wire, because if guide wire goes up, half your job is done.
No roll up overzealous ureteroscopy. And
Correct,
if
sir.
at all you want to do, it should be done with small size ureteroscope.
So, Mokani, Venkat, Hussain, and Sachin, please understand why
Okay.
everyone is saying step by step. Number one is that you have got a diagnosis by slowly injecting the dye, and if it is going into the upper tract, you are sure that it is a partial, okay, and your surgery may be successful. Now, why to put a guide wire? Because it is called a pathfinder. So even if there is a small connection present, there are very high chances that this guide wire will go into the upper tract. So many times we have seen, and just put a guide wire gently and hooray, it goes up. And things are over. The ureteroscopy, if you put it earlier, first of all, you are going to put lots of fluid inside. Okay? Because you are tempted to see the ureter. Understood? Because there are, there may be slough or there may be disruption, fibers and everything you can't see. There are chances that with this, you may cause more injury. So as Dr. Gite said, that should be the third. Dr. Maheshwari also said, it should be the third thing. There are very good chances that by putting the guide wire, if it is not totally transected, chances are very high that it will go into the upper tract.
Right.
Fine? You understood? So in the exam, how you are going to answer?
Yes, sir.
And this road map is very important.
Yes.
You can never be penalized for asking a retrograde pyelogram. Any procedure, ureteroscopy, degestenting, difficult degestenting, retrograde, always start with a retrograde pyelogram. That would definitely make your procedure safer.
Correct. Fine. Okay. So just show what was done, Brijesh?
Sir, we also did cystoscopy, retrograde pyelography, and DJ stenting over. Before putting the stent, we did under controlled situation. We did URS, and we could appreciate a narrow leak over.
So
this lead.
yeah. So what had happened, I'll tell you. When we put a guide wire, it was going into the fistula stent. So when we put a small size ureteroscope and little, under pressure, we were putting the saline, and we saw on one side, we could see the mucosa. And we realized that along this mucosa, if we put a glide wire, there are chances that it will go. And luckily, it went through, and we put a digest. So, Sachin, Hussain, Mukani, Venkat. Suppose there is a lower end ureterovaginal fistula. You have put a digestion, after 3 months you remove it, and again there is a leak. What you will do? Chalo, Sachin, what you will do? Step by step. You have removed after 3 months, and there is a leak. I have not done RGP, nothing, because I thought it is 3 months are over, and there is nothing, everything must have healed. For 3 months she was absolutely dry. I have removed the digestion.
What do you
And
think
there is
is
a
the
leak.
problem? What do you think is the problem?
Large fistula, sir.
And
Or
what do they do in
small vessels.
laparoscopy? Laparoscopy, what is the problem?
Thermal injury, sir. Thermal
Delayed.
ischemic necrosis.
Yeah.
Okay, so Sachin, now what you want to do?
Sir, reimplantation, sir. Definitive surgery, sir. Now, because till this point, patient might have subsided the infection, sir.
Hussain, what you want to do? You want to do definite surgery or want to do stent for 1 year?
Sir, definitely surgery, sir.
Definitely. Mukani, what you want to do?
Definitely surgery.
And Venkata?
Is there any role of re-imaging at this point of time, sir? Will we repeat CT urography before going into the definitive surgery, sir?
Yeah, it is showing. There is a definitely.
Yeah,
Because
if-
when the chance of
In the
giving
lower,
doing a digestant and diversion by digestant waiting for 3 months, then only answer is surgery. No
Fine.
confusion in
Okay.
mind.
Yes.
Understood?
Okay, sir.
So all of you understood. No?
You
When
have to
after
go
3
for
months,
surgery.
you have to go for surgery. Now,
That's all.
another question. It is a lower ureteric. Now,
Agar still sir is as examiner, he is asking for 1 year digestant, and in some selective patient who are highly debilitated, not able to tolerate the surgery, then in such situation, I can place the digestant and to reduce the leak. But your first straight answer is surgery.
and why there is a surgery? Because epithelialization of the tract has taken place. This is never going to heal. Understood? It is like doing your fistula in ano. Once the fistula in ano is there, it is epithelialized. You have to remove the tract. Like that. Okay. So now, second question. Sachin, you go inside and you find out in the lower ureter, you are able to see the lower segment of the ureter. Will you do ureterouretic anastomosis or you will do reimplantation?
Reimplantation, sir.
Hussain, what you will do? Ureterouretic anastomosis or reimplantation?
Reimplantation, ureteroneocystostomy, sir.
Why?
So there is a possibility that there may be, sir, fibrosis, and we may found there is a difficulty with this ureter. There is also associated. We have to excise this fistula streak also, sir. So there is a possibility that we may lose that some part of ureter also.
How often you excise? How often you excise the fistula tract? Have any one of you seen excision of fistula tract?
No, sir.
No, sir.
Then why you are talking? I'm telling you, you're able to find out the lower ureter, which is patent, for example. Because from below you put the ureteric catheter, sometimes I do it to find out, to identify the lower end of the ureter. Suppose if it is patent and I want to do ureterouretic anastomosis, is it advisable?
No, sir.
Not
Not
advisable.
advisable, sir.
Why
No,
it is
sir.
not advisable?
not to anastomosis the same at the injury site again.
Yeah. So the chances of recurrence are very high in the lower ureter because of the blood supply.
You have
And
to
second
know
is,
about the blood supply of the ureter
yes,
properly from
and
up to down.
and second thing is the fibrosis and stricture. Okay. So that is why,
there is
yeah,
no uretro-ureteric anastomosis when injury is in the lower ureter.
Yes.
Bottom line statement. If you do a uretro-ureteric anastomosis and just distal to that there is a UV junction, there is a static column of urine in that particular area that will make to fail your procedure. Number one. Number two, whatever you have already explained, that is ischemic fibrotic area all around. So chances again ischemia and opening of the anastomosis. So in lower ureter, no uretro-ureteric anastomosis.
Why Boary flap works so well? Why Boary flap works so well? Because bladder has got such a rich blood supply.
Good
Such a
vascularity.
rich blood
Yes.
supply.
fine.
One more question
Okay.
to sir's first question. So there was a stent for 3 months. Sir said we removed and there was leakage. I'm saying there is no leakage, but 6 weeks later patient has presented with pain. You have done imaging, there is hydronephrosis.
Yeah.
Stricture formation.
Biotic stricture.
So that could be
Correct.
another presentation of ischemic injury, that the fistula is healed, but it has
Stricture.
fibrosis. So again, you have to keep a watch after you remove the DJ stent called developing hydronephrosis, pain. In
Good.
such cases also you may have to go back and re-implant.
Sure.
Fine. Good. So, Bridges, we don't have any cystoscopy or RGP field.
No, unfortunately, sir, we didn't have for this case.
Okay. Fine. Okay. Sir, any other question?
अगर दूसरा केस नहीं है तो सर वसाइकोवाजिनल फिस्टुला का यूजुअली केस रहता है, उसमें कुछ पर्टिकुलर क्वेश्चंस पूछते हैं
Yes,
एग्जाम में.
first time. The first case was the vaginal fistula, ना?
हाँ, तो टाइमिंग ऑफ द फिस्टुला रिपेयर है.
हाँ,
Then
पूछो ना, सब उन लोगों को पूछ लो ना.
control of conservative treatment in the vesicovaginal fistula, number 2. Number 3 is associated diversion, that is suprapubic SPC is required or not required. Then how you remove the catheter, first your periorbital or suprapubic, first suprapubic or periorbital, uska sequencing पूछते हैं. Then what is the golden period in treatment of the vesicovaginal fistula, timing का again questions आता है. Then excision of the fistula or not excision of the fistula, one more that one more question can be asked. Then type of the repair में laparoscopy robotic अगर कोई वो एक area
Yeah,
पे कुछ
per vaginal, transvesical, and suprapubic.
Then
So,
minimal
okay,
invasive
Sachin.
treatment of the vesicovaginal fistula में कुछ अगर कोई करता है तो fulguration है, glue है, उसके बारे में questions पूछा जा
Yeah.
सकता है. तो ये सब चीजें एग्जाम में VVF का अगर केस
Yeah.
है
So let us
तो
start
आती है.
ना.
Then
Sachin कोई
principle of the
Sachin.
fistula repair, ये चीजें पूछी जा सकती है. तो ये सब क्वेश्चंस है सर.
Okay, so
अगर
let us start with the Sachin. So first of all, Sachin, in cystoscopy, when there is a vesicovaginal fistula. Okay. Now, when you do cystoscopy, tell us what are the things you will like to look for, step by step. Sachin is there? Okay, Hussein, tell us. There is a case of vesicovaginal fistula or whatever it is. But fistula is there, and now you are doing cystoscopy. Tell us what are the things you will see.
So I would like to look for this number of fistula, size of fistula, what is the location of the fistula, surrounding mucosal margin, how it is, whether the tract is matured or immature. Apart from that, I would like to also look for whether the distance from the ureteric orifice or nearness to the bladder neck. apart from that, I also I would like to do hysteroscopy or vaginoscopy also along with that, and confirm this vaginal opening and with the same findings at this vaginal site along with this capacity of vagina, sir.
You would like to put the ureteric catheter in both the ureter and see there is no stricture or there is no other fistula in the ureter.
So, sir, if I'm not suspecting,
See, like this case, no, this case, first case, you don't know, no? Sometimes there
then
may
we
not be
can,
hydronephrosis and still there may be a fistula.
so
We have come across such cases.
right, sir. So we can put a ureteric catheter and we can do RGP and confirm the same thing, sir.
Yeah. Okay. Fine. So that is number one. So you did a cystoscopy. Okay. As the sir is asking you, number two, suppose what are the other options apart from surgery? If there is a vaginal fistula, what are the other options and what are the indications?
So there is a conservative management also, sir, but specifically for this less than 5 mm, in which we are keeping the catheter for a longer time, approximately 3 weeks or longer for continuous bladder drainage. Along with that, we can do electropulgration of this fistula or this laser cautery also of that fistula strip. Apart from that, there are the fistula glue which is available, but the role is still controversial whether this intra-plug installation or between these two layers of this vagina and the bladder. These are the two main things which may keep as a consideration.
Okay.
देखो
Fine. So
कंजर्वेटिव
now,
कंजर्वेटिव मैनेजमेंट अगर डिस्कस हो रही है तो उसमें प्रोग्रेसिव डिक्रीज इन यूरिन लीकेज का हिस्ट्री रहना चाहिए, नंबर एक। नंबर दो, लेस देन 3 वीक का जो ऑनसेट है फिस्टुला का, वहां से लेस देन 3 वीक रहना चाहिए। देन इन्वेस्टिगेशन पे फिस्टुला ट्रैक शुड बी लॉन्ग एंड ऑब्लिक रहना चाहिए, एंड साइज शुड बी लेस देन 1 सेंटीमीटर रहना चाहिए। दैट मींस इट्स द फिस्टुला शुड बी नॉन कॉम्प्लिकेटेड। कंजर्वेटिव में कैथेटर विद एंटीकोलिनर्जिक इज वन, ओनली कैथेटर एंड एंटीकोलिनर्जिक। नंबर 2, पल्गरेशन बहुत सारे लोग करते हैं छोटे फिस्टुला के लिए। नंबर 3 फाइब्रिन ग्लू है, एंड नंबर 4 प्लेटलेट रिच प्लाज्मा भी आजकल कुछ लोग डाल रहे हैं, जैसा अपन डिफ्लक्स डालते थे वसा को अपना वो पीओआर के लिए टू माउंट हो जाता है और वहां से फिर वो ब्लॉक हो जाता है। तो ये 3-4 मिनिमल इन्वेजिव ट्रीटमेंट अवेलेबल है कंजर्वेटिव के। एंड डेफिनेटली कॉन्ट्राइंडिकेशन अगर है तो पोस्ट रेडिएशन फिस्टुला इज कॉन्ट्राइंडिकेटेड। स्कारिंग है, इन्फ्लाम्ड है, एडिमेटस है, फिस्टुला मोर देन 6 वीक का है और साइज अगर बहुत बड़ा है तो कॉन्ट्राइंडिकेटेड।
very good. Thank you, Gite sir. Thank you very much. So
Sir,
Hussein, what are the different surgeries you like to do?
So whether it would be a trans vaginal or trans abdominal, sir. So if we are going with this vaginal route, then it would be, sir, let's go technique, or so it would be that Mauritius flap or
So what is the, now tell me, what is the principle of the repair? Whether you do transvaginal or you do transvesical or you do extravesical.
I
So
think you
whether
should
it
have
is
just classified, where is the fistula, what surgeries are for which fistula, rather than just
Right, sir.
starting like this,
Right, sir. So whether it is which type of fistula it is, simple trigonal or infratrigonal, quite far away from this ureteric orifice, and we are not suspecting that we may require bladder augmentation or ureteric reimplantation surgery, then we may think of this we may think for this vaginal route. But if it is opposite to these points, then we may think of this abdominal route also, sir. But there is no clear-cut specific absolute contraindication for the vaginal route, apart from that ureteric reimplantation and augmentation surgery.
तो जो इनिशियली जो रूट ऑफ ट्रीटमेंट था, सुप्रा ट्राइगोनल, इंफ्रा ट्राइगोनल, abdominal एंड वजन, मल्टीपल सुप्रा abdominal, सिंगल है, इंफ्रा ट्राइगोनल है, तो ये अभी ऐसा कुछ नहीं है। इफ यू आर accustomed with any route, ट्रांसवाजिनल रहो या ट्रांस abdominal रहो, Anybody can treat any type of fistula by any one route. अगर वो ट्रांसवाजिनल से सब ट्रीटमेंट हो सकते हैं या ट्रांस अब्डोमिनल से, जो तुम करते हो वो बोलना है. यूजुअली गायनेकोलॉजिकल रूट्स अगर गायनेकोलॉजिस्ट विल डू बाय ट्रांसवाजिनल रूट एंड न्यूरोलॉजिस्ट विल डू बाय ट्रांस अब्डोमिनल रूट. ये थोड़ा सा कन्वेंशनल, क्योंकि हम वो एरिया से कंसर्न रहते हैं. तो ऐसा कुछ फिक्स रूल नहीं है. जो इंडिकेशंस अगर थ्योरेटिकली पूछा किसी ने तो बताने को आना चाहिए. ये ट्रांसवाजिनल का क्या इंडिकेशन है, ट्रांस अब्डोमिनल का क्या है. Then mature fistula, immature fistula, one more question can be asked. Simple fistula, complex fistula, that one more question can be asked. ये सब ये जो questions है ना, ये पूरे tip of tongue रहना चाहिए उसके
Sir,
answers.
you asked them, no? And Dr. Gite, I agree with you. I have assisted Somora for 2 occasions. And he has done more than 5,000 vagico-vaginal fistula, all different types, all transvaginal.
सर मेरा खुद का ही आर्टिकल है साउथ एशियन फेडरेशन ऑफ ऑब्स्टेट्रिक एंड गायनेकोलॉजी में पब्लिश हो चुका है कि कोई भी उसका कंक्लूजन ही यही है कि अगर आपका एक्सपीरियंस अगर ट्रांस अब्डोमिनल से है और रिजल्ट्स अच्छे आ रहे तो एनी टाइप ऑफ फिस्टुला कैन बी डन बाय ट्रांस अब्डोमिनल. और आप अगर ट्रांसवाजिनल से करते हो तो एनी टाइप ऑफ फिस्टुला प्रोवाइडेड डेफिनेटली सम इंडिकेशंस एसोसिएटेड यूरेट्रिक इंजुरी है, यूरेट्रोजनल फिस्टुला है, मल्टीपल फिस्टुला है, ये अगर है तो डेफिनेटली ट्रांस अब्डोमिनल रूट से जाना चाहिए.
Correct. Yeah, fine. But in exam, you can do the classification and can say these are the things we are following.
क्लासिफिकेशन
Now-
सब डेफिनेटली पूछते हैं. क्लिनिकल क्लासिफिकेशन है, रेडियोलॉजिकल क्लासिफिकेशन है, गाव क्लासिफिकेशन है, वाल्डी क्लासिफिकेशन है, बहुत सारे क्लासिफिकेशन है. तो एटलीस्ट क्लिनिकल क्लासिफिकेशन तो पता रहना चाहिए और सिंपल कॉम्प्लेक्स फिस्टुला क्या है वो पता रहना चाहिए.
Fine. तो आप दूसरा क्वेश्चन पूछो ना उन लोगों को. दूसरा क्या था?
क्या बोले सर?
Other questions you wanted to ask them, ना?
नहीं, अभी तो 11 बज रहे तो पढ़ने दो.
ठीक है. ओके. ठीक है.
ये क्या है कि सर उनको थोड़ा होमवर्क भी तो देना चाहिए ना.
Yes. No problem. We will
Dr. Rajkumar
come
had joined,
again.
sir, today.
Hi, Rajkumar. Good evening, Rajkumar. How are you? Fine. Okay. So in one of the clinic later on when we are doing the surgeries, we will remember this vasovaginal fistula and we will discuss about it. Okay.
Yeah, thank you, sir.
Fine.
Thank you.
Okay.
Thank you, sir.
It was
Thank
a
you,
nice
Rajkumar.
discussion.
Thank you, sir.
Yeah.
Thank you. Good night.
Okay,
night,
sir. Good night, Gaurang sir, Gite sir, Pankaj sir, Dr. Rajkumar
Everybody,
sir.
good night, sir. Good
Right,
night.
good
Good
night.
night. Good night. Good night.
Good job, boys.
Thank you, sir.
Well done. Well done.
Right.
We'll make you expert. Don't worry. Hello, sir.
It was a very nice discussion and very helpful for the PGs.
Keep joining, sir.
Yeah,
Please join. Please join.
sure. I got the link today, so I joined. Yeah.
Yeah. Good, sir. Good to have you. Bye.
Same here. Bye. Good night.
Good night.